Welcome, everybody. Thank you for sharing a little bit of your evening with us while we kick off this series. As Bob said, considering ways that physical therapy can help you with your back pain. And I hope that I can give you a brief overview, perhaps over the next 40 to 45 minutes, and then kind of open up things to questions. But Bob, thank you for the introduction, and let's go ahead and begin. So I'd like to share just a few back facts with you as it relates to back pain in this country, but also globally. In this particular study, as there are many, back pain is of great significance to us, not only as medical professionals, but should be as a population as well, because it commands a lot of attention, not only in the disability that it imparts or can impart, but also in the cost that it imparts on the medical system. In this particular study, in 2018, both men and women were surveyed about their back specifically. And as you can see here, 28% of men and 31.6% of women had back pain or experienced back pain in that 3-month period or prior. And what we see is really an escalating incidence over time. Thankfully, when we're young, we usually, in most cases, don't have a whole lot of joint and musculoskeletal issues. But depending upon the activities that we participate in, and certainly as we age, as some of these bullets will show, oftentimes people have an experience of back pain. And in fact, as the statistics say here, 85% of Americans will experience back pain at some point in their life, and the incidence really escalates after the age of 50. Likewise, from a global perspective, as I had mentioned, low back pain is the leading cause of disability in terms of musculoskeletal injury. A few more statistics here that I just wanted to bring your attention to. Again, low back pain really commands great attention. It is so common. And as professionals, we have, I think, a great opportunity in front of us, but a great challenge too, as we try to manage this condition. And the research continues to be forthcoming on best practices for treating a condition or conditions, if you include the cervical, thoracic, and lumbar spine. That is a challenge. As you can see here too, in the lower right-hand corner, services such as primary care visits to physicians or other specialists that are utilized in the management of low back care contribute to all those costs. Physical therapy is also a cost as well in the medical system, but I hope that you'll see over this presentation that I believe, and the research is beginning to substantiate, that physical therapy,
not sure I understand.
When placed in the right position in the healthcare management of low back pain, can really mitigate or decrease cost. So let's talk a little bit about what is not working long term. There's a lot of research, again, that shows multiple different interventions. In fact, if you go on to Dr. Google on the internet, you can find all kinds of different type of treatment interventions. But what we know from a literature standpoint is that opioids are certainly not the intervention of choice. As a matter of fact, the prescription and use of this modality is becoming less and less and much more highly regulated, simply because of the potential for addiction. Physicians and other providers that are prescribing medications have really changed their prescription patterns to prescribing much more analgesics and anti-inflammatories versus opioids. And there are multiple medications in the field that can be much more effective, as well as less risk to addiction. Bed rest or inactivity. Back when I started practice, the general guideline was bed rest up to 14 days. And that is certainly not the case today. In fact, the converse is true, is where we try to encourage activity as soon as possible to ensure that blood flow and movement are activated immediately. And as we say in the industry, motion is lotion. So we got to move to heal the back. And that's more important today than ever. Especially, given some of the events that we've experienced in the last 3 years, when people can be really kind of in home, if you will, especially during a pandemic. So lastly, just some of the interventions that you might find out there in the field are PRP or platelet-rich injections or stem cell injections. There's research going on out there in regards to injecting stem cells in discs to try to improve the viscoelastic properties of discs, kind of heal or regrow discs, and the research is just not substantiated that is a viable solution right now. From a surgical standpoint, I'll bring up some facts here. So 62% surgery has increased 62.3% in that period from 2014 to 2015. And those for something like spinal fusion, that incidence or use of the surgical modality is continuing to escalate. And in the same turn, the cost of having a surgery of this nature, which I always call the Cadillac of spine surgery. It is the biggest and most costly of the spine surgeries, especially when you're talking potentially single fusions or single level fusions versus multi-level fusions for big surgeries like scoliosis or kyphosis. It's very expensive. And if you look at the reoperant rates, it's pretty significant. You're looking at 1 in 6 to 1 in 5 people have a reoperation, and that is that consideration is typically not because the surgery itself fails. In fact, the surgical relief or the surgical benefit is actually quite good. It's the segments above and below the level of the fusion that take on a significantly higher amount of stress or percentage of stress, and at some point those segments often fail or have issues, especially if they had some issues going into the surgery. But any good surgeon's not going to just continue to move up or down the chain. They want to address specifically the areas that have the highest incidence of issue. So what can help? Well, that's why we're here tonight. I want to talk a little bit about physical therapy and things that we can do to help you with your back pain. I think anybody that was seeking intervention for their back pain, which again can be very debilitating, extremely painful, would always opt for a conservative measure. And of course, I'm biased. I've spent a career studying conservative interventions or non-surgical interventions for low back pain, and it's effective. It's very effective, in fact. And of course, sometimes back pain patients are going to need surgery or other interventions. But as a specialist in musculoskeletal care, that's where we can help you determine if you need to go see a specialist by referring you on to somebody that can help you in the event that we can't. So in this case, let's talk a little bit about early access. It's one of the most important pieces of intervention. We need to be thinking about how quickly you can get in. And in most of the states in this country, we actually have direct access. So you can see a physical therapist off the street if you have musculoskeletal symptoms. And with the, there's always an exception if you have a certain insurance company that requires a prescription. In this case, federal plans often require that, such as Medicare would require a prescription, but otherwise, for most private health insurance, you can see a physical therapist off the street, and I think you should for musculoskeletal injuries, because it decreases a lot of the cost, and in many cases, of course, the pain that is associated with prolonged back pain. So I feel very strongly about, and the research backs this also, that PTs are uniquely qualified to treat musculoskeletal injuries. In fact, I consider myself and my colleagues primary musculoskeletal specialists. If you look at the literature, there are no better providers for screening musculoskeletal symptoms than physical therapists and orthopedic surgeons. So and especially when they work together, I think the power of physician and therapist working together is excellent. So early access is really a way to help mitigate the symptoms that you're feeling. So, and oftentimes when we'll see folks early on, the length of their stay or the length of their episode of back pain is lessened, which also can lessen the long-term use of any type of medication, as well as decreasing the costs. And oftentimes, we may even be able to completely mitigate the cost of needing diagnostics with a favorable outcome. So again, we won't go there. I throw in multiple references throughout the presentation, and I have a reference list at the end as well. And I'm not going to read these verbatim for you to go specifically into each of the research articles. But the research is emerging and showing very favorable conditions where if the physical therapist is the first provider seen and/or kind of the first provider of choice, that cost and incidence, or I shouldn't say incidence, I should say longevity of back pain can be significantly managed. Likewise, early PT for acute care, as I said, and there's a spectrum of people that we see in our clinics each day. Some folks have acute low back pain that may have happened in the last week or two. Other people have what we would consider chronic pain that can go from 3 months and beyond. But again, early access to physical therapy is really one tenet where I think we could make a huge difference for our patients by trying to start managing those conditions early on. In this statistic and this study done in 2015, by getting to PT first, the average decrease in spend or total healthcare dollar spend was almost $5,000 less than other providers, simply because you eliminate, in many cases, the cost of office visits, injections, diagnostic imaging, and other services that may not be needed for a back issue. I'll share these bullet points with you in total so you can kind of read down there. But again, a lot of evidence out there, and I again want to share this with you because I don't feel that many people really understand the scope or the levity of how therapy can help people. And if therapists are really first as a primary care musculoskeletal therapist, a lot of things can actually be lessened. So if you look at some of these things, 53% of folks are less likely to receive surgery, 46% less likely to need or require an MRI, 11% decrease in long-term medication use, and on average for each episode of care, you're looking at $1,200 to $2,200 less. And in this day and age, when people have copays exceeding $50 per visit, and deductibles or high deductible plans that can easily range from $6,000 to $10,000, managing cost is a very important aspect of what we bring to the table when we're managing conditions as serious as low back pain. The American Physical Therapy Association did a study actually I think it came out in September of this year, if I'm not mistaken. They looked at 8 different conditions and looked at the average decrease in spend or dollars saved, if you will, for all these different conditions by seeking physical therapy first. The article it's a big one. It's over 100 pages, but it highlights each of these conditions and how they arrived at these dollar numbers or decreases in spend. Very interesting. Again, emerging research continues to support these facts. So other than early access to therapy, something else that we can do as therapists is take inventory or do an evaluation of you. And we do a very thorough job of evaluating spine conditions and or any of the musculoskeletal conditions. And as it says here, we don't just treat the pain, we're trying to find out what the pain generator is. And when you come into the clinic, it all starts with a conversation. We'll get some information from you through your medical history and then discuss, those things that are impacting your quality of life, your function, perhaps your strength, and or imparting symptoms on you, such as numbness and tingling, pain, inflammation, weakness, those types of things. And we really want to find out what things are ailing you so we can establish a good plan of care for you to help you get better. And then lastly, as we're, again, vitally interested in establishing that relationship with you, we want to set concurrent goals. Every patient that comes in has a different why or a different reason why they need to get better, whether that's work or play or being able to spend time with their families and loved ones. Those things drive a need or a desire to be able to get better. And those are some of the things that we focus on to make sure that we're establishing a plan of care that's individualized to you. In the traditional model, when you had a back pain episode or you injured yourself, you would see your physician. You would be prescribed a medicine of different kinds, whether it's anti-inflammatories to analgesics all the way to opioids. You would modulate activity, or as the old saying goes, "Hey doc, it hurts when I raise my arm." Well, don't do that. And then, oftentimes, you'd actually be referred to a specialist in the case that where you saw your primary care physician as the first point of entry. If your symptoms didn't resolve, they would send you on to a specialist. Well, in this, as I say, the emerging trend, or really the trend that's before us right now, is what we should be thinking is when there are musculoskeletal injuries or musculoskeletal symptoms, you should go see your therapist first. The therapist can do an evaluation, use their musculoskeletal evaluation skills to prescribe a plan of care for you and interventions for you. And then if you get better, then you can just, reach out to your therapist in the event that you have a small recurrence or exacerbation. Or if symptoms are not being mitigated, we can be your trusted advisor to send you on to a specialist. That is our role. It's really two things. It's one, can we provide a reasonable outcome for you? And number two, if we can't, then we need to look for specialists that can help you. And that could be any number of healthcare providers. Number three, we can identify the problems. Again, the classic medical care, medical model will tell you what's hurt. We want to tell you why it's hurting. Again, we need to find the pain generator. And by doing the things that we've been trained to do on an expert level, looking at your medical history, looking at your examination findings, and explaining those things to you, we can decide or determine if you have a good prognosis for recovery and discuss that with you, and then create a treatment plan that hopefully is very effective for you to resolve your symptoms. And there's a lot of things that we look at during the evaluation. If you've been to therapy before, you might recall that your therapist looked at your mobility or your motion. They looked at muscle testing, your strength of your arms, your legs, maybe even your core stability. Took some reflexes to make sure that your nerves were working appropriately. Checked your motor control, meaning do you have good posture or postural awareness? Do you move in space well when you're doing different activities? such as squatting or walking or bending or twisting, and perhaps what things could be at fault there. And again, looking at higher level activities, if you were an industrial athlete working in a very high pressure or high activity job, or a student athlete, or even a collegiate or professional athlete, where we might have to look at higher level activities that need to be done for your activity of choice. We also do things or introduce modalities or other treatments that help you with your inflammation. There is some medication that we are allowed to administer by the pharmacy board. In this case, if you're in Ohio and it's the Ohio Pharmacy Board, we can administer a medication called dexamethasone. But that's just one small thing that we could administer, and we do that through a patch. But there are many ways to decrease pain and inflammation. We prescribe exercise. The research continues to become more and more compelling that we can decrease pain and inflammation through exercise, specifically aerobic exercise, when we get into an aerobic range between 50 to 70% of our target heart rate. We can use manual therapy techniques, joint mobilizations, and or manipulations. Some clinicians provide manipulative treatment in addition to mobilizations. Modalities such as TENS, electrical stimulation, or other modalities, and even things such as therapeutic tape. In this picture off to the left, I know it's a little fuzzy, but you can see what happened over a very short period of 2 weeks, where a significant hematoma on August 1st in the upper left-hand corner, by using therapeutic tape, became significantly better. And by using the taping, you can apply the tape in such a way that can help create space in between the different tissue layers, so that can help move that fluid out and away, and allow new blood flow and oxygen and such, all the good stuff to get in there to heal that injury or heal that hematoma over time. So again, just a few examples of things that we could utilize. There are many clinical practice guidelines that we use that help us inform our treatment. And we won't get into those right now or right here, but there are significant amounts of research that inform the clinical practice guidelines for the cervical and lumbar spine, and we utilize those to help us provide best practices when getting people better. Next, just talk a little bit about mobility, and there are a lot of things that we can do for mobility, whether that's a loss of flexibility from muscles and tendons, or whether there's loss of joint mobility. Again, we can use manual therapy to do that, whether that is passive range of motion of extremities or joint mobilizations or manipulations. We can use assistive stretching or teach you how to stretch yourself. Again, which is always a part of our goal and our plan for you, is to help teach you how to administer treatment to yourself so that you're an active participant in your care. And then devise a specific home program to show you those exercises so you can continue to do them in between treatment sessions. Now, typically, we're going to see people 2 to 3 times a week for 2, 4, 6 weeks for most conditions, but it could be more than that depending upon what intervention was done, such as a surgery. That could certainly take longer periods of time, but in the end, it's about allowing you to get back to your previous function and having quality of life. Another thing that therapists can provide is just addressing strength issues. Many people have strength issues, whether that is after injury or even as we age. Some statistics that you read say that after the age of 55, we can lose 1 to 2% of our strength each year if we're not participating in regular exercise, particularly resistance training. And there are things that we can do to address that. Again, we can do resistive exercises through our hands, or manual therapy. We call those proprioceptive exercises, or PNF exercises. We can use machines or exercise equipment. Most of our facilities are stocked full of different exercise piece of exercise equipment, but ultimately we want to be able to show you some really skilled or higher level activities that require things that we could show you, even something as simple as a mat, such as in this lady in the picture doing a yoga exercise, or things that are really more specific to the issue at hand versus just machines. And functional training. Once we have the mobility and we have the flexibility and the strength, we can continue to layer those things together so that you can have more functional strength doing activities that you need to do or you love to do, such as squatting and standing and walking, hiking or sports, or dancing with your spouse or significant other. So. And then we can address the control problem. Actually, that should say the motor control problem. And what does that mean? Motor control. It's being able to synergistically use your muscles to perform functional activities. There's a lot of things that go into being able to walk, for example. For a patient that has spinal surgery and they have a large shell brace on, coming out of that brace can be very scary, and maybe they, for the last 2 to 3 months, have walked with a very short stride and walked very guarded and have difficulty navigating stairs or sitting down in the commode or getting up out of their car. We would start with more simplistic activities, such as maybe some basic flexibility, mobility, or strength exercises for the core and for the legs, but as we improve or go down through the continuum of care, we can make those activities more challenging and layer them in such a way where you're able to do functional tasks again, so that you can do your basic ADLs, your activities of daily living, effectively. Next, we provide a personalized program. I think the art and the science come together when we really provide a program that specifically addresses people's individual needs. In our system, we have an app that's called MySelectPT, and when patients come in, we devise or create an exercise program or a home program for that patient that can be individualized through our app. And then the patient has a choice. They can either get those exercises on paper if they prefer that, or they can just download our app after they created an account, and they have the accessibility to both written instruction and video instruction. And not only that, but if the patient needs to communicate with their therapist, of course, you can always pick up the phone, but you can actually directly email your therapist through the app, and the therapist will get the email in their work account so that they can directly respond to you. And that happens sometimes. Our patients are performing an exercise. Maybe they need some basic clarity on the exercises, or they have questions about icing or heating after therapy that maybe wasn't completely addressed in the treatment program, or maybe they got home and they realized that they didn't have moist heat. They only have dry heat, or a heating pad that they plug into the wall, and they just want clarity. Which is better? Is it okay if I go 15 or to 20 minutes when you recommended 10? Those types of things. And it's a great way to facilitate communication between therapist and patient. I think whether you went to Google or whether you spoke to a friend or a friend of a family, hopefully many of you that are on this call have experienced therapy with us. We're very proud to say that our patients, they like what we do. They like the outcome that they get when they come to therapy, and we're not afraid to talk about it. I think that is one of the great things about going to providers that you trust, is that you can work together not only for a short period of time, but in many cases a very long period of time, for years in fact, I know myself, I've treated parents, grandparents, children, and children of children over the last 30 years, and it's very gratifying. And we are thankful for our patients when they're happy, and when when we are able to exceed their expectations. And when we get a chance to talk about it, I think our therapist would say it with a smile, because it means something. It's the reason why we get up and come to work every day, is to try to make impact for other people.